All right, good morning, everyone. This is Stephen Butters, product manager here at VisualSonics headquarters in Toronto. Welcome to our January, although it's February 1st, webinar, close enough. Today's topic is going to be contrast-enhanced ultrasound imaging, and we'll dive into advanced data analysis with VevoCQ. And our presenter is Sandra Meyer, one of our application specialists. But first, just some notes about the webinar. We are recording this webinar, and a recording will be made available. Usually takes about a week or so after the webinar is finished to edit the video and get everything up. So for those of you who have to step away or know somebody else that wants to watch the webinar later on, just stay tuned, and notification will be sent out when the recording is available. All of the lines are muted for the duration of the webinar. If you do have questions to submit, which we absolutely encourage you to submit questions as we're going through the webinar, please use the questions panel that you'll see on your screen there. We will have a session to answer those questions at the end of the webinar. So we're expecting around 40-45 minutes or so for presentation, and then around a 10 or 15 minute period for questions afterwards. And if we do get swamped with questions, certainly we'll take a little bit of extra time to try and address those questions as we go. So our presenter today is Dr. Sandra Meyer, who has been with us here as an application scientist with VisualSonics for quite a number of years now. Sandra's comes to us with a background in biology, initially working on developmental genetics, and then transitioning into cancer research, looking at glucose metabolism, solid tumors, and their radioresistance in those tumors from Johann Gutenberg University in Mainz, Germany. She's been an application scientist with us for quite a number of years, and is quite experienced in all of the different areas of our imaging platforms, including all the applications of high-frequency ultrasound, obviously contrast today, as well as all of the other techniques and things that we use, as well as our Photoacoustics platform. And Sandra has lots of fun bouncing around in Europe, doing trainings and demonstrations and educations for preclinical researchers all over the European continent and beyond sometimes. So we'll pass the presentation over to Sandra now, who's going to take over and walk us through her presentation. So take it away, Sandra.
Thank you, Stephen. And depending on where you are, good morning, good afternoon, or maybe even good evening, everybody. Thanks for joining us today. It's my pleasure to present to you some contrast-enhanced ultrasound imaging and more specifically advanced data analysis using the VevoCQ software today. And the outline of today's webinar, I hope you can all see my slides. Yes. The outline of today's webinar is quite simple. We start with I said short introduction when we set up this webinar, but going through the data, I realized that we really didn't have a real contrast seminar webinar for quite a while. So maybe the short introduction is slightly longer than I was aiming for in the beginning, but nevertheless, from there we'll move on to some examples from the literature, and then we'll dive right into the VevoCQ analysis, looking at the different models, quantification, and I'll also show you a brief glimpse of the software itself and show you how to navigate around. And then in the end, as Stephen just said, we'll have a short or slightly longer, maybe question and answer session. So let's get started. What is ultrasound contrast imaging? Well, ultrasound contrast imaging itself is quite simple. We are using a contrast agent, which in our case is a tiny bubble, a gas-filled bubble. And once this gas-filled bubble is hit by the ultrasound beam, it starts oscillating and gives us a very specific ultrasound signal back, which we can easily detect. And the advantage of using this tiny gas bubbles, these contrast agents, is that once they are injected into the bloodstream, they highlight the vasculature of our preclinical animal models. So once we start imaging and we inject contrast agents, we can clearly see where blood flow is in our tissue, in our region of interest, and we can see really which areas of tissue are perfused, as you can see. There's different types of contrast agents, and the one that's mostly used for perfusion imaging is a so-called Vevo MicroMarker for contrast enhanced applications. This is a tiny gas bubble. The gas core is perfluorobutane, and this gas core is protected by a phospholipid layer, phospholipid shell. These small gas bubbles are normally 2 to 3 microns in size, meaning they can easily travel throughout the whole vasculature. But the important point here to note is that these bubbles stay within the vasculature, so they don't travel into any other tissue. And this is what allows us to really monitor perfusion using this MicroMarker contrast agent. Another type of contrast agent is very similar to the MicroMarker, but it is used for targeted imaging. And with targeted imaging, in this case, we mean that we can look at biomarker expression within the vasculature. This is important, of course, as I just mentioned, the bubbles stay within the vascular network. And the build of these bubbles is very similar. They also have a gas core and a phospholipid shell, but in this case, streptavidin molecules are included into the shell, and they allow us to use a biotin streptavidin coupling to connect these bubbles to a ligand, an antibody, a fragment of an antibody that you would like to use to target your cell surface marker to study this biomarker expression. Both contrast agents have in common that we will image them in our nonlinear contrast software, which is available for Vevo 3100, 2100, and also our laser and laser X systems. And you would use a 21 or 50 megahertz transducer, as we find, or as it is a fact, that these frequencies respond best to this very special ultrasound signal we get from the contrast agent. And then a nerdy side fact, if you're wondering how we are detecting this specific bubble signal, how the imaging itself is done. In case of the Vevo systems, the nonlinear contrast mode we apply uses amplitude modulation to obtain the nonlinear microbubble signal, and we are doing this at the fundamental ultrasound frequency. So it's not subharmonics or anything we are using, it's a fundamental frequency of the bubble. Once you start imaging in contrast mode, the normal process is that you have the B mode image and the nonlinear contrast mode image side by side, and you would inject your MicroMarker through vascular access into your animal. And the first model I would like to discuss with you is a bolus perfusion. So in the terms of bolus perfusion, the setup is pretty simple. You normally regularly put in the tail vein catheter, you inject your contrast agent while you're imaging your area of interest, and you can see as the video starts over how the contrast agent is rushing into your tissue. In this case, it's a subcutaneous tumor. Once you have recorded a video clip like this, you can draw a region of interest and look at something that is called the time intensity curve. So we are looking at the echo signal, the contrast signal in our area of interest, and you get this time intensity curve, which is the signal that we record. And as you can see, this time intensity curve can be divided into 2 phases. After the bolus, we first have a wash-in phase, and we reach a sort of peak. And then gradually we have wash out a bit steeper in the beginning, and then it looks like we are reaching a plateau, but this is because this is a rather short time span we are looking at. If you would image for a couple of minutes, you could actually see that the contrast agent also gets washed out again. And if you want to know what effects wash in and wash out, well, the wash in and the early wash out phase is determined by the vascular distribution of the contrast agent within the tissue, meaning we inject the contrast agent through the tail vein, and it moves up, it comes into the right ventricle of the heart, it goes through the lung, it comes into the left ventricle, and then it really distributes throughout the body. And depending on how close you are to the heart, how well vascularized your tissue is, you can see this peak of this contrast agent washing in. And then the wash out phase is determined by several parameters. It's first of all the clearance by the mononuclear phagocytic system. It's a non-specific bubble retention that we have, and it's also microbubble collapse. And these factors can be quite important if you want to look into longer cine loop acquisition of your contrast agent signal. So this is Bolus perfusion. Another way of studying perfusion is a so-called destruction-replenishment model. In this case, we are also injecting some contrast agent, but now we start imaging only when we have reached a steady state of circulating microbubbles. Once we have the circulating state of microbubbles, we start recording, we image for a short period of time, and then we give a high power ultrasound burst to destroy the bubbles in our field of view, and then we can basically see the reperfusion, the bubbles rushing in from the tissue surrounding our area of interest. So once again, we have a region of interest that we outline, and we can look at the signal. It's much simpler than the one before because we have this more or less steady state plateau. Then we have the destruction and the replenishment phase. One thing to note here is that if you want to do a destruction replenishment model, it's required to have a steady state of circulating microbubbles. If the concentration of the microbubbles changes all the time while you're doing this imaging, then your data won't be consistent, won't be good. So this is something to point out here. And the third model I would like to introduce to you today is contrast imaging for targeted biomarker expressions. This is the second type of microbubble that I showed you in the beginning of the presentation. So we are using, in this case, targeted microbubbles to study the expression of biomarkers within the vasculature. And in terms of imaging, this type of application combines the two imaging sequences I showed to you before. So you would inject the contrast agent, you have a wash in, you have a wash out, and then later on, you see that there's some signal quite stable. It stays in this case, in this graph, for a couple of minutes. And then what's interesting for us, what we want to know is really happening right here at the end. So let me explain the workflow. We inject our targeted contrast agent and we wait about 4 minutes. This gives the microbubbles time to find to and bind to the target that you want to analyze within the vasculature. And after about 4 minutes, we would start imaging. And in this case, we are imaging the circulating and the bound targeted micromarker. We then once again give this burst sequence and disrupt the bubbles in our field of view. And then afterwards, the only thing we have left in terms of signal is the circulating micromarker, and also the non-specific background signal from the tissue. Analyzing these type of application, you could get time intensity curves like this. And if you're wondering why we are having two here, this is very easy to explain, similar to immunohistochemistry studies. In this case, you would always need to look at an isotype control to account for unspecific binding. Then you would wait a couple of minutes until all the bubbles are cleared, and you would repeat a bolus injection, this time using your targeted micromarker to really study biomarker expression of your interest. And once again, a side note on the side here, depending on the affinity and avidity of the ligand and also the expression of the target in your region of interest, the wash-in phase of this targeted bubbles may be different than the one in non-targeted bubbles. And if you want to do a study where you want to assess both perfusion and targeted enhancement, you should do some testing before to make sure that the perfusion curves you get are reliable in this case and not affected by the binding of the bubbles. So to sum this up and to give you an overview, we've seen 3 different MicroMarker applications so far. We've seen the 2 on the left, Bolus perfusion and Destruction-replenishment, and these are both used to study tissue perfusion or tumor perfusion, if you wish. And I used with MicroMarker, the untargeted version. The bolus injection is a somewhat easier setup because you don't need to take care of the steady state of circulating microbubbles, which is sometimes a bit more difficult to reach in especially mice because their blood volume is so small. However, if you do a bolus perfusion, you must take care to really standardize your workflow. So you have to make sure injection rate, volume, and bubble concentration are kept quite similar. Destruction-replenishment model, as just stated, requires a steady state, but once you have the steady state, the advantage of this version is that you also may study multiple imaging planes in your area of interest without repeated injection of contrast agents. And as a last thing, the differential targeted enhancement, as I just mentioned, you have to do 2 injections here, isotype control and targeted MicroMarker. And then this allows you to study biomarker expression. As I already hinted at in the last slide, there's quite a few parameters you need to be aware of when doing contrast imaging studies. And these all will affect the data that you get, the quality of your imaging, the quality of the data that you can obtain. So for contrast imaging in general, a standardized workflow is quite essential. Points to consider are, for example, the contrast agent preparation and concentration, the delivery method. In this case, it's been shown that handheld injections have more variation than, for example, if you're using a pump. And if you're interested in using a pump, there's different models out there. There's also one from VisualSonics that can be integrated with the workflow on the 3100, so you have control of the pump settings on the machine itself. And you also should make sure that you keep the system settings and acquisition parameters quite constant, and here I can only suggest that you always use the presets to make sure you are consistent in your workflow. And as a last point, animal physiology is also quite important, and you should always make sure to keep the physiology as close to the normal level as possible. And if you would like to know more about all these parameters that may affect your contrast imaging acquisition, there's a very nice review article from 2013. It's Haviland et al. And they discuss a lot of factors that may influence the outcome of your contrast agent study, and also provide a very good background if you start looking into contrast agent studies. And I'll have a list of the publications that I'm showing you throughout the webinar at the end of my slides, so you don't need to write that down right now. You can just have a look at the slide later. So far, we only talked about contrast imaging itself, but of course, it's important to also note that it's very rare that you just want to do contrast imaging. Normally, you have a bunch of questions you want to answer if you start imaging, and probably one very important one for whatever target organ you have or whatever application you have is anatomical information. So before you really start digging into your contrast image acquisition, what you would normally do is have a look at the B-mode imaging. In this case, I'm showing you a kidney here. And as you can see, we can do 2D imaging of the kidney. We can add some linear measurements, some basic measurements, or we could also acquire a 3D of the image of the kidney and do volume reconstruction here. And if you've imaged your area of interest a couple of times, are now very well familiar with how the data looks, how the image looks, then it's quite easy to also spot pathologies. For example, this is the polycystic kidney I'm showing you here. You see it's really blown up, it's full of cysts, and if we compare the volume, then it's more than 5 times the volume of a normal kidney, as you can see here. And of course, knowing these anatomical facts before you start imaging in contrast mode is quite important to find your target or to analyze your target. As a next step, it can also be very interesting to look at some functional information, and especially when we talk about contrast imaging, blood flow information is crucial. So we could use the color Doppler on the Vevo systems to look at whether we are having larger vessels in our area of interest. In this case, we are looking at the renal artery and vein. Or you could use the power Doppler and the pulse wave Doppler to get some more information. Pulse wave Doppler would allow you to measure blood flow in these larger vessels, whereas power Doppler allows you to assess the amount of vascularity within your region of interest, either in 2D or also in 3D. So this could be very nice complementary information to see which bigger blood vessels do I have in my target, around my tumor, or in the organ I'm studying at the moment. Then we come to the contrast, to the contrast imaging itself. And from what you've seen so far and from what I've told you, what we can see here is we have the larger vessels in the Doppler imaging, but then if we want to study perfusion down to the capillary level, contrast imaging really is the way to go. And this highlights all the areas in the tissue where you only have perfusion at the capillary level. Above and beyond ultrasound imaging, there's some other capabilities on the photoacoustic systems that we have, the Vevo laser and the Vevo laser X. And these would allow you to not only study perfusion, but also look at oxygen saturation of tissue directly. So for example, in this video clip, we are monitoring live changes of the oxygen saturation in kidney and spleen as the mouse is breathing first medical air and then is switched to 5% oxygen and back to medical air. And you can follow changes in oxygen saturation live in this setup. And as in oxygen saturation measurements or in photoacoustics, in this case in general, it's not required to add any contrast agents. Sorry, somehow my slide jumps here. Oh, I'm very sorry, this slide doesn't work properly. Okay, so you can only see the small picture on the top right here, where you can see that we also can monitor oxygen saturation in the whole abdomen, in the whole body of the mouse here, which is nice to see. And as a last step, I hope this works now, you also can add other molecular information using photoacoustics, where we can study, for example, kinetics of injections of different dyes. In the example I brought you here, we have Avens Blue and ICG. And we can monitor this in vivo biodistribution over time. So we have one image before injection, 30 minutes after injection, and you can see the ICG is distributed in the gallbladder, the liver, the intestine, and the Avens Blue already pretty much drained to the bladder at that point, marked with the B and the yellow dot. And then 24 hours afterwards, the Avens Blue pretty much has cleared and only ICG signal is left. So something's really wrong with my slides here. Here we go. Okay, sorry, once again. Oh, so here you have the full overview. So using the whole imaging capabilities of the Vevo systems, you can really go starting at the anatomical information, adding functional information, studying perfusion, and then using the photoacoustics, you could also go more into molecular information, looking either at endogenous signal and like oxygen saturation, or also study molecular information and kinetics here. This may sound a bit vague now, a bit abstract. To make it a bit clearer, I brought you some examples from the literature to show how other researchers are using these capabilities to pursue their studies and gain more information from their animal models. The first publication I have here is from 2016. It's Freeling and Raswani, and they established basically the imaging of a murine colorectal cancer model in ultrasound and contrast imaging. So first of all, they looked into how well they can detect and size the colorectal tumors using ultrasound imaging, high-frequency ultrasound imaging. And they were very happy with how they could follow up on tumor growth over time, as you can see on the left. But then more importantly, they also wanted to learn more about how these tumors are perfused. And they did some contrast imaging here. And as you can see, this is a supplemental figure, a short video where you see the bolus perfusion of the contrast agent as it is injected. But they not only show you the video, but they also show some example images and some analysis here. So we see on the left side a mouse that has a small colorectal tumor load. In the middle, there's moderate tumor load, and on the right side, there's heavy tumor load. And after contrast injection, Freeling and Raswani compared the two parameters, peak enhancement and wash-in rate here. So as you can see, as the tumor progression moves on, you get a much higher peak enhancement signal, and you also get a higher wash-in rate. And what these parameters mean, we'll come to in a second. So this is one nice example how you could study tumor models using the Vevo systems. Another example about tumor detection is this paper from Bachawal et al. And it's from 2017, as far as I remember. So in this case, no, it's 2015, sorry. In this case, the group, first of all, identified a target that could be a tumor marker in humans, and the target is B7H3. And once they had identified the target, they started to do some contrast imaging, first of all, making sure that these target can be used to do contrast imaging with targeted microbubbles. So they injected the targeted microbubbles into their flow chambers with their cells on a microscope and assured that these bubbles really bind to the target they had in mind. They then moved on to a small pilot study in animals where they checked that they really get an enhanced signal using these bubbles, as you can see on the left. And then they used control bubbles, the isotype control that I mentioned earlier, and they also blocked the B7H3 target in vivo and got a significantly reduced result. So they saw that these targeted microbubbles can really work in their animal model to study the expression of B7H3. And in the last step, they imaged about 180 mice and found that in comparison to normal mice, B7H3 expression is greatly enhanced in these mice having breast cancer. So they think that in the long run, this could really help to improve the accuracy of diagnostic ultrasound screens also in the clinic, if you not only do an ultrasound screening, but get the molecular information for B7H3 on top of that. The third model is also about targeted imaging, and in this case, the question was whether you can use targeted ultrasound contrast imaging to monitor tissue inflammation after irradiation. Once again, the workflow is, as I showed you, you have 2 injections, one for non-specific microbubbles on the left, and then the targeted microbubbles, this time they're targeted to P-selectin. And then they irradiated half of the animals or the treatment group and repeated imaging after 24 hours. And as you can see here, these are the pictures. They got control at the 0-hour time point, and the treatment group and the 24-hour control group have very low signal of P-selectin, and the treated group, the irradiated group, 24 hours afterwards has a greatly enhanced P-selectin signal. So they concluded that you can use this molecular contrast enhanced ultrasound imaging to monitor tissue inflammation and monitor effects of this treatment. And the last publication I would like to show you today is Fan et al. From 2016. In this case, it's a huge study looking at the efficacy of VevoCQ and another chemotherapeutic agent, CRLX-101, and different combinations of these 2 treatments to fight breast cancer. And most of the paper, or a lot of the paper, is survival groups, survival graphs for different treatment groups, and studying the effects of these 2 chemotherapeutic agents. But they're also looking into some mechanistic data. And they found that one problem with VevoCQ as a chemotherapeutic agent is that it greatly enhances HIF-1 alpha expression, which causes the tumor to be more malignant, and that the combined treatment with CRLX-101 reduces expression of HIF-1 alpha. And this also improves how you can treat these tumors, so survival rate is much better. And to see what really is different on a functional level, they did some contrast imaging, and they could show that untreated tumors, or tumors treated with VevoCQ, have a low perfusion. So the 2 parameters they study, as you can see down here, are peak enhancement and wash-in rate again. And combining the treatment with CRLX-101 or using it alone, you have greatly enhanced perfusion. So peak enhancement is rising over the 3 weeks of therapy, and the wash-in rate of contrast agent is also better, showing that the tissue is better perfused, the vascular network is more functional, and this allows you better treatment. And in addition to doing contrast imaging, they also looked at the photoacoustic signal and the oxygen saturation in tissue, and found that this complementary information supports their findings that CRLX-101 improves tissue oxygenation as well, and helps downregulate the HIF-1 alpha in this case. Okay, so we've seen that you can get some nice data, that other people publish some nice data using contrast imaging, but from what I showed you in my introduction so far, we've only seen the bolus infusion, we've seen some time intensity curves. Now the question is, how do you get to have these nice images? How do you get to have some numbers, some parameters you can work with? And the answer for this really is to run some analysis with the VevoCQ software. The VevoCQ software is an additional module to the VevoLab software that you use to analyze your standard Vevo data. And there's some available resources for you to help find your way around the software. There's the VevoCQ user guide version 1.1. This is quite important. There's some older versions around, but make sure you have the user guide 1.1, and you can download it from our customer website if you don't have it yet. And also there's a VevoCQ software webinar that talks about the workflow, how to click through, how to run the software in a bit more detail than we'll have time for today. So if you're interested in seeing that, I'll also have the link at the end of my slides. So basically, if we look at the data we record in our Vevo system, if we look at the time intensity curve, you see that we have this line here. We have a lot of dots, we have a lot of data points, but the signal overall is quite noisy. So you can look at it, you can make some assumptions, but doing quantification out of this data is quite possible. So ideally, what we would like to have is a nice clean curve and nice clean signal to run our analysis. And this is what VevoCQ does for you. How does it work? First of all the data that we record, all the video data that we record on the Vevo systems and that we have in Vevo Lab is log compressed data, okay? The time intensity curves you see on the Vevo systems are based on the linear raw data, but the video information is log compressed. Now, if you start the VevoCQ software and you load your data into it, the data will be linearized once more, and this is important because this makes the signal that we get proportional to the local contrast agent concentration. And because of this transformation and because of all the parameters that influence which signal you record, which data you record, only relative measurements are possible when doing contrast imaging using the Vevo systems. The clip length that you can load into VevoCQ is limited to 1,000 frames. This is important to know before you start recording your data so that you can set up your experiment accordingly. And once the data has been linearized, a curve fitting approach using a parametric perfusion model is applied, and output parameters are calculated from the fitted curve. So it's two steps. It's linearizing the data, and then it's curve fitting. And together, it allows us to get from this pretty rather noisy raw data curve on the left to the clean data on the right that will be analyzed in VevoCQ. Output parameters are either amplitude related, and in this case, they're expressed at relative echo power in arbitrary units, or they are time related and expressed in seconds. And this then normally refers to a timing of contrast uptake kinetics, whereas the amplitude related parameters are associated with relative blood volume. And then, of course, there's some combined parameters that use both as an information. Going back to the contrast applications that I showed you earlier, going back to the models, we have the Bolus perfusion model first. And here you can see a schematic of what you expect to see in VevoCQ. You have the linearized signal as gray dots, and you have the perfusion model as the red line. And key parameters, as you saw in the literature that I just showed you, are peak enhancement and wash-in rate. Peak enhancement is basically how much more signal do we have at the peak level of perfusion compared to the baseline, and the wash-in rate is the maximum slope of the rise of the wash-in phase. The second model we had is the Destruction-replenishment model, and this is quite easy. In this case, there's less parameters to look at. There's amplitude and there's mean transit time. Amplitude, once again, is how much more signal you have after replenishment than compared to the baseline. And the mean transit time is when you reach half that level, and is giving you a time component here. And as a last thing, differential targeted enhancement compares the level of ultrasound signal of your contrast agents before and after the destruction pulse. And as you remember, probably before the destruction pulse, we have signal from the bound bubbles and from the circulating bubbles, and afterwards we only have the circulating bubbles. So if we take both levels and compare, we can get a parameter for differential targeted enhancement here. And this allows us to find out what our biomarker expression is. Using the software is actually quite easy. You can either load clips into VevoCQ either directly from the contrast image that you recorded in VivoLab, or you can select several images from the study browser. And as I said before, Stephen has some details about this in his webinar, so I'm not going too much into details here. You do have some information about the image that you entered here up on the left. And you do have the option that if you load several clips, you can jump between them using the previous and next clip button here. There's also a help function available that will take you to the VivoLab help, where you can read up on all the different models and the information that I just presented to you here. And then most importantly, no, not most importantly, sorry, there's an option to correct motion. This is only applicable if you have in-plane motion. So normally this would refer to motion when you do imaging in a sagittal orientation. Let's say you have some liver tissue that you're imaging and you have the movement of the respiration. If you're imaging in a sagittal view, you could correct for in-plane motion using this button here. If you have out-of-plane motion due to respiration, then you may consider using the respiration gating on the Vevo instead. So there's several options here. And then, of course, you want to add your regions of interest. And you can either load regions if you have analyzed the tissue before, or you can draw up your own region. I normally start by adding a rectangular region over the whole contrast imaging box to get an overview. And then I also use the B-mode image to draw an area of interest, in this case around my subcutaneous tumor. And once you have done that, you would start up the quantification software, and now we are going to jump right into the VevoCQ software here. As you can see, the log video data from the Vevo system has been linearized. This is the weak, more pointy, more rigid curves that you see here, and then we have a smooth curve in yellow for the yellow region of interest and in green for the green region of interest. And this is the fitted signal that we have here. Sorry, I'm just trying to. Oh, sorry. No, I found the button. I just had to hide the webinar sidebar here so that I can actually see the data that I'm showing you. You have the fitted signal in the first view, in this view that I selected here, but you can jump in between the different parameters of the VevoCQ software by selecting them from this drop-down menu. Let me run you through them briefly. So the fitted signal is the bold green curve you have here, or the yellow curve for the yellow area of interest. The linearized signal would be the linearized signal before curve fitting. And you can also look at that. And for these two, you also have the option to click play here, and you will get a playback of your Bolus Perfusion recording with this parametric image on the top right that allows you to nicely see the perfusion here. Let's stop this playback. Then you can select different parameters also. There's peak enhancement, as I just showed you earlier, peak enhancement as a relative measure of blood volume in your area of interest. And you can add up to 4 different regions of interest in your video clip to analyze. And you can, this is also important, the system, the VevoCQ software, auto sets gain and dynamic range for this parametric imaging up here. But if you want to compare data between animals, you can either manually select a gain level here, or you can also make some presets for all the different parameters and change how your data looks here. So if you want to compare between animals, make sure that you always use the same gain settings on the top right here. Other parameters, we can look into the area under the curve for the wash-in phase. So basically the area under the curve of the fitted signal. You have the rise time. This was also displayed in the graph before. It's from the base of the wash-in phase until you reach peak enhancement. Time to peak is starting from the beginning of the analysis to the peak enhancement. You have wash-in rate as the maximum slope of your wash-in phase. And you have wash-in perfusion index. As you can see, this is the area under the curve divided by the rise time. And as the last 2 points, there's an area that basically just displays how large your area of interest is. And the other point is quality of fit. Now, there's a lot of discussion about quality of fit. And as you can see here in my example, quality of fit for my subcutaneous tumor area is pretty good. It's 39.9%. Excuse me, I'm getting confused here. This is pretty good, and this is roundabout what I would aim for when running analysis. I like to be in the 90% region. For the whole region of interest, for my whole contrast imaging set, quality of fit is rather low. And this can be because I have some artifacts in my image. I have some air bubbles here. I have some areas where maybe my image is saturated. And overall, the signal from this large area that also consists of some ultrasound gel and some shadowing. So overall fit is pretty bad. So normally, I would only look at the quality of fit for my real region of interest and not for the whole. And if you don't want to have this overview of the whole contrast region anymore, you can just delete this region of interest and focus on the tumor that you actually want to study and look at the different parameters for the green region that is my subcutaneous tumor here. There are a couple of other parameters available that are not based on the curve fit we are seeing here, but that are based on extrapolated data. If you go to the user settings, as I just did, and activate this button here, you can actually activate these parameters. And now if we go to the drop-down menu, you see you have this extra parameters here based on extrapolated data. This function is available, but I would always treat this information with a bit of caution. Once you have analyzed your region of interest, you've set your parametric imaging, gain, and dynamic range to a level you like. There's some export functions available up here if you click on this. And this actually takes me back to my presentation as the very last slide. Sorry, I jumped a bit here. So this is the data export as I just showed you. You can select it here, and you have several options. You can export this parametric images. You can export the movies that I showed you for the linearized and the fitted signal, and you can export all the data as you wish here. And a very nice function that I also like to use is up here. There's one option that says export screenshot to Vevo report. This will save a screenshot of the VevoCQ analysis with your normal Vevo lab data to remind you what you got and that you ran the analysis on this here. Okay, I think I've outstretched the time that I had a bit, so let me conclude and let me show you. These are links to the webinars that I mentioned, the VevoCQ webinar applications and workflow, and the September 2017 webinar on photoacoustic imaging. And this is a list of all the publications that I showed you in this webinar. And with this, I'd like to thank you for your attention, and I hope there's a couple of questions. Stephen, do we have some questions?
Hi, yes, we do. Sorry, a little delay there. Great presentation, Sandra. Thank you for the overview. It's really really in depth and really shows.
Yeah, I'm really sorry it took a bit longer than expected, but I think, yeah, as I said before, we didn't have a contrast and CQ webinar in a long time, so there was a lot of information to get through.
Yeah, no, it's true, and there's always lots to talk about, especially with this subject. You can get pretty deep if you want to. So we've had a few questions come in along the way. I kind of sent a couple of them over to you, but I don't know if you had noticed during the presentation, so I'll read them off.
No, I haven't.
Sure. So one of the first questions that came in was, can we image the brain through the mouse skull? So if you want to take that one.
Oh yeah, that's fine. Actually, this is a very good question. And there's a couple of studies that have used contrast imaging on brain. There's also some publications about this, if I remember correctly. There's one also, for example, from Sunnybrook in Toronto. However, the challenge with imaging the brain in contrast imaging is that you have to get signal in and out going through the skull, which is taking a lot of signal. So when doing contrast imaging, what most people have done in the past is they have made a window into the skull to image, and then it was possible to use contrast. Having the latest innovation in terms of photoacoustics, I think nowadays, if you are interested in brain imaging, maybe photoacoustic imaging could be a better option, because in photoacoustics, you can actually leave the skull intact and get a lot of information from the brain, like oxygen saturation, not doing any window models.
Yeah, I agree fully. I mean, yeah, it's always a concern with altering the physiology. Anytime you introduce any kind of a hole, a burr hole, or a skull window, or anything into the imaging situation. So yeah, I really like the PA application for that as well. Being able to get the signal right through the skull intact and get back out is quite nice. I've got a couple of questions here that I think they're a little more technical, and I might take them instead. Sure. One is, what is the comparison of Vevo MicroMarker to SonoView and other ultrasound contrast agents? So kind of the short answer to that one is that the MicroMarker for the Vevo systems is designed and manufactured specifically for use with the Vevo systems at high frequency. The way that the bubbles are sized will make them function much better, will give you much higher sensitivity on the Vevo systems than using another agent, say like a SonoView or a Definity, or even a sort of a homemade one, where the range of bubble sizes might be quite a bit broader and might have larger bubbles in there, where the sensitivity is not going to be quite as high. Having said that, you can use other contrast agents on the Vevo platform. They do work. Just again, be wary that the bubble physics, as it relates to high frequency ultrasound specifically, may not work quite correctly. Another one, actually from the same person, is asking about the MI, or the mechanical index, that's used on the Vevo system. So this is kind of an interesting topic. We have numbers for the MI on our systems with all of our transducers, and we can share those with customers. Just send in a request through the website, through scientific support, and we can get back to you with those numbers. We don't share them widely, because the high frequency ultrasound platform means that the way that the relationships are between the transmit frequency and the transmit power and other aspects makes the MI numbers, calculating the MI numbers a lot more challenging. We often say to people that are really into contrast imaging that it's actually better, because of all of the variability that can be introduced into these types of things, if possible, if you can measure them yourself. But we can, yeah, certainly share the numbers that we have, and just contact us for that. So then a follow-up question to that one about the Vevo MicroMarker versus SonoView, and asking about publications. No, we don't have any publications that I know of, that I'm aware of, where people have done comparisons of MicroMarker versus any other bubbles. I know from my own personal experience, having tried Optison and Definity and some homemade bubbles in sessions at customer sites, and also here in our lab in Toronto, where we clearly get more signal and more stable signal with the Vevo MicroMarker than with any of the other ones. I can think of a time when I was using Optison one time, and I mean, as soon as the bolus injection was done, there was a signal there, and then it was gone very quickly. Those bubbles seem to be very transient and unstable. There may be publications where people have compared, not that I'm aware of. Sandra, have you seen any comparison publications?
No, not really. Not that I remember right now. But to chip in some hands-on experience, I've once done some imaging with SonoView in a customer lab, and in that case, we also compared SonoView and the MicroMarker. And in this case, the signal we got from SonoView was much weaker than the signal we tend to see with our MicroMarker. So it seems that the frequency of our transducers don't work too well with this slightly larger bubbles.
Yeah, that's kind of been my experience. Been my experience as well. Another question that's come in just about the actual sort of process and mechanics around the injection itself, about gaining vascular access, methods for that, and any sort of like tips and tricks for reproducible, consistent injections.
Oh yeah, that's a good question, and I think this is one of the big challenges many users face when starting contrast imaging. Is like, how do I get the contrast agent in? From my experience, a tail vein injection normally works best, and we are actually using cannulation to do this. So we are putting in a tail vein catheter in the mice or rats, and we use the catheter to apply the bolus injection or the constant perfusion while imaging, which has the advantage if you use cannulation that you don't have to manipulate the animal directly while you're imaging, so you're not moving your imaging plane, or you're not moving the imaging while you do it. There's other ways of injecting contrast agents. Retroorbital is one way, but it's somewhat more invasive than the tail vein, so this would only be possible for a final examination, for a final procedure. And the other option would be a jugular vein cannulation. But speaking from a European standpoint, I think both are not common in Europe. In Europe, the tail vein access is the preferred method. And with a bit of practice, it actually works very well, and it can also be done several times on the same animal if you give it a bit of time to recover.
Yeah, that's been my experience here in North America as well. Just that you know, there are other methods. I've seen retroorbital injections done. I've seen jugular vein cannulations done, but they're definitely a lot more invasive, a lot more acute, versus the tail vein cannulation is a nice method that can be done over and over again, which really lends itself well to longitudinal studies. So that's definitely something that I would promote over retroorbital or any of the other methods. A question about the syringe pump. This is something that certainly I've heard, and Sandra, you've probably heard too. An attendee wondering about whether or not it is actually a good idea to use a syringe pump because of the bubbles settling in a syringe during the injection. If you could speak to that.
Yes, actually, that's a very good question. Using a syringe pump is definitely good in that you can be highly reproducible with your imaging, that you can very standardize, giving the same amount of contrast agent at the same speed at all times. But the bubble setting in the syringe is a point that you have to consider. The best way that I find doing it is that I draw up the contrast agent from the vial into the syringe directly before doing the injection. So I draw up the contrast agent into my syringe. I put the syringe into the pump, into the injector, and start imaging right away. I'm not sure it could really work, but we've discussed with some customers before whether it would be worthwhile trying to put the infusion pump on a shaker that keeps the syringe moving while you're doing the injection. I still think it's a fascinating idea, but I haven't tried if it works. Maybe if you're doing a lot of animals and this is a big concern for you, it may be worth trying this. Just putting the...
It's funny that you mentioned that. I actually remember one time putting a syringe pump on a rocker and trying that, and I think it didn't work. I think it didn't work because the volume in the syringe is so small, and there's no the bubbles are not heavy enough to be able to be moved from the oscillation of the rocker, and there's also no airspace in there. And I kind of feel like the shaker might be the same thing, unless it was a really high velocity shaker. One thing I saw is, it sounds kind of goofy, but it seemed to work, an electric toothbrush. I actually saw somebody holding an electric toothbrush against a syringe and a pump one time, and it introduced enough of a vibration into the syringe that it seemed to keep the bubbles up and keep them settling. So yeah, it's definitely, the settling is definitely an issue for sort of a longer term thing. I think maybe one of the solutions is speed, really. Just keep it short and don't do it
like
too
I
long.
said, draw up the volume that you need for the injection and start imaging, set it into the pump right away. Don't let it settle. And then of course you have to repeat for every injection, but at least you have the bubbles in good shape when you inject.
And I think, people obviously would be concerned that vibration might burst the bubbles too there, and it's definitely possible. That's something that would maybe require a little bit of checking or pilot studies. I feel like with just a little quick tap or something like that it wouldn't have enough of an issue. I think you'd really have to hit the bubbles pretty hard with something to vibrate them. They are fairly durable. They are sensitive to pressure, definitely, but they are durable enough to not be broken apart.
To stand some movement. Yeah.
So I think we have time for one more question. This is actually a good one. I'm just wondering if you could speak to, you mentioned on one of your slides the sources of variability, and I just wondered if you could kind of expand on that a bit and talk about some of the major and minor sources of variability and just elements of good design of experiment to try to control for those.
Yes, I think that's really one of the key aspects when doing contrast imaging is the variability that you may see. And one of the biggest sources of variability from my point of view is definitely the micro bubbles itself, meaning you have to reconstitute your bubbles before you're getting started. They are sitting in this vial. You have to withdraw them, you have to make sure they don't settle, as we just said. So there's a lot of room for error here, and the best way to deal with this is to really be consistent. So for example, when resuspending the bubbles, make sure you always use the same syringe, you always use exactly the same amount of buffer of saline to reconstitute your bubbles, to make sure you always get the same concentration, and also make sure that you handle the bubbles carefully. As Stephen just mentioned, the bubbles are solid enough when it comes to movement. They can move, they can travel through the bloodstream, but if there's a bit of pressure, they will pop very quickly, and this definitely should be avoided. So make sure you vent the vial, make sure you always slowly draw up your contrast agent, and most importantly, when you give a bolus injection, make sure that you don't have any pressure on the syringe. Have a nice constant pressure on the syringe to inject, and keep this part as good as possible. Other sources of variation, as I showed you, this publication from Haviland et al. It's actually the last one on my list here. I hope you can still all see my slides. Use of ultrasound contrast agents, microbubbles in preclinical research. They also, for example, show that if the body temperature of the animal drops by 4 or 5 degrees from 37 to 32 degrees, your peak enhancement parameter can be half of what it was before, because perfusion, when the animal gets cold, really drops rapidly. And this is another parameter you should definitely be aware of and take care of. And as a last parameter, or a last factor for variability, it's definitely system settings. So if you think about your Vevo imaging system, you have most importantly parameters like gain and frame rate. And these should be strictly controlled. So use presets, always apply the same settings, because if you record your video clips at different gain levels from one animal to another, this will give you completely inconsistent results.
Yeah,
okay?
Yeah, definitely. I concur. That's a really good point. The gain, the system gain is a really important point to try to standardize that, to keep it consistent. Sorry, we actually stole presenter rights back just before you mentioned that last slide. So for anybody that was wondering, just earlier in the presentation, just refer back to that summary slide that Sandra showed that has all the papers on it there for that paper that she was mentioning. Okay, well, we're just a tad over time, so we're going to wrap it up. So thanks again, Sandra, for the overview. It's an excellent overview of contrast and some of the issues, and definitely some of the advanced data analysis. Contrast is a really interesting area of research and imaging, and certainly something that you can really get quite in depth into data. As I mentioned, we did record the webinar. The recording will be sent out after we have a chance to check it out. It'll be on our website. If there's an address there for our website for past webinars and past recordings. Keep tabs on our website and connect with us through our website with any questions about support, whether it's technical support or scientific support. There's some forms to fill out on the website to submit them. And we are always out at conferences and various society meetings, so we maintain a list of upcoming conferences on the website that we'll be at. If you see that we're going to be at a conference, stop by and say hi and ask us any of our questions. We virtually always have applications, scientists and product folks there at trade shows and meetings with us that can answer any of your technical questions. So thanks again, everybody, for joining us, and we will sign off for today. Bye.